When I first started seeing long COVID in 2020, like a lot of clinicians, I was looking for one main cause, one mechanism, one explanation, one, this is what long COVID is. And early on, it really did look neurological. It looked like the autonomic nervous system was the center of the storm. Hi, my name is Dr. Robert Groysman from covidinstitute.org, and today we're going to be talking about the six primary mechanisms of long COVID as well as other mechanisms and why or not they're considered primary or not. In the beginning, people were coming in with tachycardia, dizziness, adrenaline surges, POTS like symptoms, and the classic fight or flight pattern. So I did what made sense based on what I was seeing. I focused on stabilizing the autonomic nervous system. And at the beginning, I was offering stellate ganglion blocks because it often helped calm that system down. But then something happened. Different types of long COVID started showing up. Patients who did not fit a pure autonomic explanation. Not just POTS, not just fight or flight, a different pattern, then another pattern, then another. And eventually it became impossible to honestly say this is only an ANS problem, autonomic nervous system. It became clear long COVID was not a single cause condition, it was a multi mechanism syndrome. This is exactly what major research reviews and cohort work have been saying. And I quote, long COVID is biologically diverse, multi system, and driven by multiple overlapping pathways, not one universal mechanism. So I did what many of you have done too. I started combing through the mechanisms, and there are many. The big list, proposed long COVID mechanisms, is shown right here. This is not exhaustive. As you can see, there are many mechanisms listed that could possibly be causal or secondary or even amplifying. This many mechanisms reality is well described in high level reviews. I will discuss right now the six mechanisms that I have chosen as primary and caused directly by COVID, and these mechanisms directly cause long COVID. These six were not chosen at random. I chose these six because in the majority of patients I see, these six meet a specific standard. One, COVID can plausibly and directly trigger them through known biology. Two, each one can independently create a wide symptom burden. Three, they frequently overlap and amplify each other. Four, they're clinically actionable, meaning you can actually do something about it with the information. Other mechanisms do exist, but many are either less common, more downstream, or explain a narrower slice of long COVID. What I am saying is that each of these mechanisms listed can cause long COVID in a small subset of patients, but doesn't and can't explain long COVID in the majority, which is why I focus on the six mechanisms that I will describe. So let's go through the six, not as labels, as cause and effect biology, and as patterns you can recognize. The first is dysautonomia, POTS and fight or flight. These are both subtypes of dysautonomia. Why would COVID cause autonomic dysfunction? There are several reasons, and they can stack at the same time. One is inflammation affecting the vagus nerve and the autonomic pathways. COVID can attack the support cells and the blood vessels that support both the nerves and the brainstem, where the vagus nerve starts. There is evidence supporting vagus nerve inflammation, and it's linked to autonomic dysfunction and COVID related illness. And this provides a plausible bridge to persistent symptoms. Two, there's immune disruption and autoimmunity hitting the autonomic signaling. Some studies show and report association, but not causality between long COVID symptom severity and autoantibodies. These autoantibodies are targeting receptors involved in vascular and autonomic regulation. There is no proof yet, however, that these autoantibodies are the cause of the long COVID symptoms. Three, there's vascular and volume regulation problems that force the body into compensation. This is where POTS comes in. If your vessels do not constrict normally or your microcirculation is impaired, your heart rate rises to maintain blood flow to the brain. That is not anxiety, that is physiology. And there's also endothelial injury, which is repeatedly discussed as a contributor to long COVID symptoms persistence. Small fiber involvement in some patients. Autonomic fibers are small fibers. If they are irritated or inflamed, the autonomic nervous system becomes unstable. So dysautonomia is not one single thing either. Even this, the one of the mechanisms is not a single thing. It can be driven by inflammation, autoimmunity, vascular dysfunction, and nerve irritation all at once. This is why early in the pandemic, the it's all autonomic idea felt true, because autonomic dysfunction is so common. But it was not the whole story. The second mechanism, mitochondrial dysfunction. This one explains a lot of what patients describe as crushing fatigue, post exertional crashes, exercise intolerance, and muscle heaviness, brain fog that worsens after activity. Why would COVID damage energy production? The direct infection of the virus itself damages mitochondria. There are proteins in the virus that cause damage to the mitochondria. That in itself is okay, in that our body can recover and repair damaged mitochondria in the future. It typically takes 1 to 2 weeks. The problem is COVID also damages the repair mechanisms of these mitochondria, so that even after it's gone, the symptoms persist, the damage persists. The SARS-CoV-2 infection is linked to immune and metabolic reprogramming, oxidative stress, and impaired cellular energy pathways in a way that can persist after the acute phase. Think about mitochondria as your cellular power plants. If they're not producing energy efficiently, you can feel exhausted even when you're doing nothing. And when you push, you crash. Major reviews specifically highlight mitochondrial dysfunction as a plausible underpinning mechanism in long COVID, tying it to energy deficits and broader systemic effects. This is also why two people can have fatigue, but one has mostly dysautonomia fatigue and another has true metabolic energy failure fatigue. Same word, different biology. Let's talk about the third mechanism, gut dysbiosis and impaired barrier function. This is one of the most underestimated mechanisms in long COVID. Why? Because people think gut issues only mean diarrhea or bloating. But the gut is also an immune organ. And when the microbiome shifts and the gut barrier becomes more permeable, that is, it lets things through, you can get persistent immune activation. This includes an endotoxin signaling like LPS driven inflammation. LPS stands for lipopolysaccharide. There are multiple reviews describing microbiome alterations in post COVID conditions and how gut microbiome shifts can interact with systemic symptoms through immune and metabolic pathways. So, COVID can contribute by disrupting gut immune balance during acute infection, altering microbial communities, changing intestinal barrier signaling, driving downstream inflammation that affects the brain vessels and autonomic nervous system. This is why some patients feel worse after certain foods, or develop new histamine intolerance, or develop worsening fatigue linked to GI flares, gastrointestinal flares, because the gut can become an upstream amplifier. Let's look at the fourth mechanism, histamine dysregulation and mast cell activation. Not everyone meets strict criteria for MCAS, mast cell activation syndrome, but many long COVID patients develop a mast cell like pattern: flushing, hives or itching, wheezing or throat tightness, food and supplement reactions, gastrointestinal urgency, that would be like diarrhea, tachycardia with exposure to a trigger, head pressure, headaches, worsening brain fog with triggers. Mechanistically, Mast cell activation and histamine related inflammatory pathways are actively discussed in a COVID and post COVID context, including evidence of mast cell involvement and inflammatory signatures. And clinically, this overlaps heavily with dysautonomia, especially the hyperadrenergic patterns. This is those adrenal dumps. So, COVID can contribute by triggering immune activation that primes your mast cells, sustaining inflammatory mediator release in susceptible individuals, interacting with the gut barrier and microbiome changes, amplifying autonomic symptoms through vasodilatation and reactivity. This is the mechanism that makes people say, I can't tolerate anything anymore. This is a reactive immune signaling problem. Let's look at the fifth mechanism: endothelial dysfunction and microvascular injury. The endothelium is the lining of your blood vessels inside. If it is inflamed or dysfunctional, you can see poor oxygen delivery to tissues despite having plenty of oxygen in your body. Exertional intolerance, anytime you try to exercise, chest pressure or shortness of breath sensations, cold hands and feet, blood pressure instability, brain fog related to impaired cerebral perfusion, exercise crashes that feel like oxygen debt. We know these things happen because COVID, the SARS-CoV-2 viral infection, can directly damage the endothelial cells inside these blood vessels. Spike protein also can damage these cells. Some groups also discuss microclots or fibrin-related microvascular obstruction as a possible contributor in subsets of patients, though the field is still debating measurement standards and clinical translation. Even without a visible clot on a CT scan, microvascular dysfunction can still impair your tissue and how it's perfused. And this mechanism can feed directly into dysautonomia. If your vessels cannot regulate, your heart rate compensates. If your microcirculation is impaired, your body stays in survival mode. That's the whole fight or flight motif here. Let's look at the sixth mechanism: hormone and stress system imbalance. This includes the thyroid axis, adrenal stress signaling, sex hormones, and a broader neuroendocrine regulation. To be precise, not every long COVID patient has abnormal standard hormone labs, but hormone signaling can still be disrupted at the tissue level, and illness can dysregulate endocrine axes even when labs look normal. COVID has documented effects on endocrine systems in general, and long COVID focused reviews discuss the complexity of endocrine findings, including variable results across cohorts. So, COVID can contribute through inflammation mediated suppression of normal hormonal signaling, hypothalamic pituitary axis disruption in susceptible individuals, thyroid signaling changes, and sometimes transient, sometimes persistent gonadal axis disruption, especially in prolonged inflammatory states, sleep disruption and circadian system disruption that also destabilize cortisol patterns. When this mechanism is prominent, we see patients describe feeling wired but tired, sleep that looks normal on paper but feels non restorative, new anxiety like sensations without any anxiety story, loss, what we call the no reason anxiety, loss of resilience, crashes that happen from minor stresses. However, hormones do not exist in isolation. They sit on top of mitochondria, immune signaling, autonomics, and endothelial function. So, if you only treat hormones, but the real driver is mitochondrial dysfunction or endothelial injury, you may not move the needle. So, in closing, about the six mechanisms, they are dysautonomia, which again is split into POTS type dominance and fight or flight dominance, mitochondrial dysfunction, gut dysbiosis, and barrier loss or dysfunction, histamine and mast cell activation pattern, endothelial dysfunction and microvascular injury, and of course the whole microclot thing in there too, hormone and stress system imbalance. And the point here is not to pick your favorite. The point is to identify which one or which ones are active in you, which combinations and what strength, which one is dominant. Because two patients can share the same symptom and have completely different root causes. This is why single cause theories fail so often. And this is why a multi mechanism approach is not complicated for the sake of being complicated. It is the simplest model that matches the reality of long COVID. If you want real progress, stop chasing one universal answer. Start identifying your active mechanisms. This is how you turn long COVID from a mystery into a map. Now, a fair question is, if long COVID has many proposed mechanisms, why are viral persistence and immune dysregulation not in my core six as the primary driver for most people? Let me be very clear. I am not saying viral persistence is impossible. I am not saying antivirals or monoclonals can never help. What I am saying is this. For the majority of long COVID patients, the evidence so far suggests that they are not the dominant universal upstream driver. They may be an important in a subset of patients, but not for the majority of people with long COVID. Long COVID is not one syndrome with one switch that one drug or treatment or supplement is going to turn off. Let's talk about viral persistence. Yes, we have evidence that SARS-CoV-2 components can persist after acute infection. There are studies showing circulating viral antigens in the post-acute phase, even many months after infection. There are also tissue studies showing viral RNA persistence and ongoing immune activation signals in some individuals. So, persistence is not a crazy idea, it's a legitimate hypothesis. But here's the key clinical question. Is the persistence in most long COVID patients, and does it reliably predict symptoms? That is still not established. We also have population level evidence suggesting that true persistent infection with ongoing high viral loads for extended periods of time is uncommon. One large community surveillance analysis estimated persistent infections lasting at least 60 days at roughly 0.1% to 0.5% of all infections. Viral persistence does not explain long COVID in the majority of patients. And the clearest, most dramatic example of prolonged viral replication and shedding are often described in immunocompromised patients, where immune clearance is impaired. So the strongest version of the viral reservoir story fits a subset very well, especially immunocompromised patients. It does not automatically fit most people. Now, what about viral remnants like spike protein or mRNA fragments? This is where people can get misled. Finding viral fragments does not automatically prove they are causing symptoms. In fact, some studies examining post acute viral antigen or RNA persistence include cohorts and tissue banks that contain donors with and without long COVID, which means detection alone does not automatically equal long COVID. So, clinically, if a marker can show up in people who do not have long COVID, then that marker alone cannot be your explanation for most cases. It might still matter, but it is not a reliable universal driver. The treatment reality check here. Broad antiviral benefit has not shown up yet. Let's talk about treatments. If viral persistence is the main upstream cause for most patients, you would expect a signal with antivirals or targeted antibody therapies in well designed trials. But so far, the strongest randomized data in established long COVID has been underwhelming. There's no evidence for this. There's no difference from placebo in several trials. For example, a randomized placebo controlled trial of extended nirmatrelvir ritonavir in long COVID did not show statistically significant improvement in health outcome compared with placebo. And if we look earlier in the disease course, even when monoclonal antibodies reduce severe outcomes in acute COVID during the actual infection, that did not translate into reduced long COVID risk in a large randomized trial. So could antivirals or monoclonals still help a subset? Yes, absolutely. Could we eventually identify biomarkers for that subset? Also, yes. But the current evidence does not support the claim that one antiviral or one monoclonal is going to fix most of long COVID. The fallacy. They just have not found the right antiviral yet. Now, there is a common argument I hear all the time. They just have not found the right antiviral or monoclonal, and once they do, we will see viral persistence is the most upstream cause. This argument sounds reasonable, but it has two major flaws. Flaw number one, it becomes unfalsifiable. If every negative trial gets dismissed as wrong drug, then hypothesis can never be disproven. This is not scientific thinking. That is moving the goalposts. At some point, repeated lack of broad clinical benefit forces you to consider that the mechanism you're thinking about, while real in some, is not the dominant driver in most. Flaw number two, it ignores long COVID heterogeneity. Long COVID is not one syndrome. It is a multiple overlapping set of symptoms mechanisms that cause this syndrome. So the idea that one upstream mechanism will explain all of them conflicts with what we see clinically and what mechanistic reviews keep emphasizing. Multiple pathways can contribute, and different patients cluster differently. If one mechanism truly dominated the majority of cases, you would expect more consistency in phenotype and a clearer, reproducible universal treatment response. We do not see that. Now let's address immune dysfunction. Does COVID deregulate the immune system? Absolutely. There's abundant evidence of immune activation, altered innate immune signaling, and longer term immune abnormalities in some long COVID cohorts. But here's the difference between a causal upstream mechanism and a downstream amplifier. Immune dysregulation is often a consequence of multiple upstream injuries. If you have persistent endothelial inflammation, ongoing gut barrier signaling, mast cell activation patterns, dysautonomia driven stress physiology, and mitochondrial oxidative stress, your immune system will look abnormal. That does not mean that your immune system was the original root cause in most cases. It means the immune system is involved and it is being driven. Another key point people sometimes describe this as if COVID directly infects and destroys most white blood cells like HIV. That is not how SARS-CoV-2 behaves in most people. SARS-CoV-2 primarily targets respiratory and other tissue cells, where entry factors are present. In circulating immune cells, ACE2 expression is generally low or absent, and when ACE2 is detected, it is often limited to subsets of immune cells or tissue macrophages at sites of infection rather than broadly across circulating white blood cells everywhere in the body. There's ongoing research on whether certain immune cells can be infected or carry virus in limited ways, but that is not the same as saying that most white blood cells are infected in most patients. So what does COVID do instead? It triggers immune dysregulation through how? Intense cytokine signaling in the acute phase. That's the cytokine storm. Innate immune evasion and immune reprogramming. Endothelial injury and microvascular inflammation. Gut microbiome shifts and barrier signaling. Persistent inflammatory loops in susceptible individuals. All of these can create lasting immune abnormalities without direct widespread infection of the white blood cells. So to summarize, viral persistence may be a key driver for a subset. That a subset, we're talking about a small percentage of long COVID sufferers. Immune dysregulation is real and also common, but neither has proven to be a single dominant upstream cause for most long COVID patients. This has not been shown. Lastly, let's talk about autoimmunity as a primary mechanism. This topic gets confusing fast because people hear the word autoantibodies and assume it automatically means autoimmune disease. It does not. Autoantibodies are not the same thing as autoimmune disease. Autoantibodies are surprisingly common in medicine. They can appear transiently after infections, and that does not mean a person has true autoimmune condition. or that the antibodies are causing symptoms. So if you run a large panel and find something positive, the correct next question should be, is it pathologic or is it an innocent bystander marker of immune activation? Because inflammation can generate autoantibodies without creating autoimmune pathology. To claim autoimmunity is the primary cause of long COVID, you would need evidence like autoantibodies are consistently enriched in long COVID compared with recovered controls. Autoantibody levels track with symptom severity and symptom type in a reproducible way. Autoantibodies have demonstrated functional effects that match the symptoms. Removing or neutralizing them reliably improves most patients. Right now, that field is mixed. There are studies showing new onset autoantibodies after SARS CoV 2 infection that can persist for months, especially after severe disease, and some associations with symptoms have been reported. But other research suggests that post COVID auto reactivity patterns are not necessarily enriched in people with long COVID compared with people who recovered, which challenges the idea that autoantibodies are the universal driver. So the presence of autoantibodies may be real, but real is not the same as causal. That means that they're not necessarily causing the symptoms or long COVID. Why this matters clinically? Here's the practical problem. If I tell every long COVID patient you have autoimmunity because a panel lit up, I may be labeling them with a mechanism that is not actually driving their symptoms. That can send them down the wrong treatment path because many autoantibodies can be low titer, that is, they're present but at low levels, transient, they come and go, and nonspecific, present after many infections and inflammatory states. So, a positive test is not a diagnosis, it is a clue that needs context. Could autoantibodies drive symptoms in a subset? Yes, absolutely. There are credible lines of evidence that autoimmunity may contribute in some patients, including experimental work suggesting patients' autoantibodies can induce symptoms like changes like in animal models, which support a potential pathologic role in subsets. We're talking about a really small set of number of people. This is what subset means here. A subset mechanism can be important without being the primary driver for the majority. My reasoning is autoimmunity is often downstream in long COVID. In my framework, autoimmunity often looks like a downstream amplifier. If COVID triggers endothelial dysfunction, gut barrier signaling, mast cell activation patterns, dysautonomia, and mitochondrial stress, then chronic immune activation follows. This is a reliable pattern. And chronic immune activation can generate autoantibodies. So the immune system may look abnormal because multiple upstream mechanisms are feeding it, not because autoimmunity is the original root cause in most patients. So my position is not that autoimmunity is irrelevant. My position is autoantibodies do not automatically equal autoimmune disease. Autoimmunity may contribute in some patients, but the current evidence does not support autoimmunity as a single primary cause of long COVID in most people. That is why I treat mechanisms that most consistently explain the majority pattern first, while staying open to autoimmune driven subtypes